All right, so we are going to get into Chapter 7 this week, Exercise Prescription for Healthy Populations, with special considerations. So we're going to mainly be talking about children, older adults, and people who are pregnant. So let's go ahead and jump in. So children and adolescents, 6 to 17 years old, they're definitely more physically active. But we still know that they're not physically active enough. Most young individuals older than the age of 10 don't meet the prevailing PA guidelines. So we still need to pay attention to how much children and adolescents are exercising, how much physical activity they're getting. So children and adolescents are usually in pretty good shape to begin with, or relatively speaking, they're usually fit enough to begin a moderate or vigorous intensity program right away. We have to monitor how much vigorous intensity exercise adolescents are doing and how much children are doing, mainly because they do have a physiologic system that's continuously changing, one of those being bone growth. This comes up quite a bit, especially when we talk about weight training, and children can obviously participate in quite a bit of vigorous intensity activity without any detrimental side effects, but you do have to monitor how much they're doing and what type they're doing to make sure that we're not putting them in a position where they could be getting injured or affecting bone growth. So one thing to understand if we're talking about exercise testing, there are important differences physiologically between children and adults. So children are going to respond different to an exercise test than an adult would. So the biggest thing to remember is we can't necessarily use the exact same tests or expect the exact same results on a child that we would in an adult, especially considering children have a much lower anaerobic capacity than adults. So, if we're doing a maximal exercise test on an adult, some people might think, well, a child, is younger, they can go for longer. That's not necessarily true. Their cardiovascular system isn't as developed as an adult's is. They have other things to consider. And when we talk about things like VO2 and VO2 max, we have to take into account body mass, muscle mass. So how much metabolic tissue are you asking to be turned on? And children just don't have as much. So asking them to do a sustained amount of vigorous intensity activity in an exercise test isn't necessarily the best way to go. There are better ways to assess their level of physical fitness. So as I said on the last slide, exercise testing for children and adolescents, even in clinical purposes, generally not indicated unless there's some sort of health concern, specific health concern. And at that point, we're going to design a test protocol specifically to look at whatever that concern is. And then another consideration is that children are going to have to be familiarized with the test, overly familiarized with the test protocol, to minimize stress and anxiety so that you can get a successful test. As far as the specific equipment that you might use, same equipment that we would use on adults, treadmills, cycle ergometers, maybe even an arm ergometer, but cycle ergometers and treadmills are going to be preferred. Treadmill is always preferred. It's always going to get you a better maximal oxygen uptake because you're using the entire body. Cycle ergometers tend to be a little less stressful and a little bit easier for someone to get familiarized with, especially a child. They have to be sized correctly, though. You can't use an adult cycle ergometer for a child. And keep in mind that because the level of understanding of what's expected in an exercise test is really important, that informed consent process is really important. A child will probably need a lot more motivation than a regular adult subject would to make sure that you get a successful test. So when we look at the physiologic differences between children compared to adults, there are definitely some things to keep in mind, especially when we're talking about exercise testing and we're talking about um, programming exercise. So as far as VO2 is concerned, you have to think that a child is smaller and has a lot less muscle mass, which will affect aerobic or oxygen uptake. Because remember, in exercise physiology, really what we were talking about a lot of the time was the muscle's ability to use oxygen to produce ATP for muscular energy. So if we have less muscle mass, that's going to affect our ability, the child's ability to produce ATP aerobically, right? So absolute oxygen uptake, remember absolute VO2 has to do with how much muscle mass you actually have. And relative is when we compare to everybody else, when we're not really taking our muscle mass into account, right? So absolute oxygen uptake would be lower, less muscle tissue to deliver oxygen. Relative oxygen uptake is higher compared to an adult. Just think that they're going to have to utilize, that they're going to have to pump oxygen much quicker at a higher rate because they don't have as much muscle mass, right? Heart rate is going to be higher, cardiac output is going to be lower, a less developed cardiovascular system, stroke volume is going to be lower, systolic and diastolic blood pressures are going to be lower, respiratory rate is higher, right? We don't have as much muscle mass to contribute to metabolism of oxygen, so we're trying to pump more oxygen in, although tidal volume is lower. That's because our pipes are smaller, right? Those bronchioles and those respiratory airways are smaller. Minute ventilation and respiratory exchange ratio are also smaller. Things to consider, differences, physiologic differences between children and adults. So when we talk about physical activity, exercise with children, what should it look like? It should be unstructured, active play, and between moderate and vigorous intensity, and it should all contribute to what the general FITT or FIT recommendations are for children, right? So as much unstructured, sporadic play as possible is best for children, right? And here are the FIT recommendations. Go ahead and get myself out of the way there for a second. Here are the FIT recommendations for children, right? Aerobic and resistance. Resistance training can also be considered bone strengthening exercises. These are the recommendations. Could be a really good source for a test question. So review these in depth. So what about strength training, right? So let's go ahead and talk about strength training. And as far as strength training is concerned, generally we can apply a lot of the same rules we use for adults. You aren't going to have an adult doing 1 RMs every single day, 100% or 200% or 300% of their body weight. So you definitely wouldn't have a child do that, right? One thing to keep in mind too with children is because they have less surface area of skin, your skin is an organ that grows with you over time. They have less skin than adults do, so their ability to cool themselves is less. So avoiding hot, humid environments for long periods of time, properly staying hydrated. Anything that we can do to decrease sedentary time with children, right? I think we all know at this point things like that contribute to sedentary time, like video games, that type of thing we want to discourage, or not necessarily discourage, but try and limit as much as possible and institute things that will help kids stay more active. Okay, so now we're going to jump into a different population, people with low back pain. So low back pain, definition here, pain, muscle tension or stiffness around or below the rib margin and above the glutes. Okay, could also come with leg pain, and it anywhere between 4 and 33% of the adult population experiences LBP, and at any given point, there could be recurrent episodes in over 70% of cases. About 20% become chronic, so over a long period of time. Just someone, I'm sure that many of you know at least one person that just always has back pain, and 10% of those cases can progress into being disabling for these folks. So something portion of the population we want to pay attention to, and one that can definitely benefit from exercise and increased physical activity. So when we classify low back pain according to ACSM, we can classify it into 3 broad categories. Low back pain associated with some other specific spinal cause, like maybe a tumor or a fracture. Low back pain associated with radiculopathy, which is fancy for pinched nerve or spinal stenosis, so hardening of those intervertebral discs in between the spine. Or a lot of times the last category, non-specific low back pain, which is basically almost all the cases. You can do lots of tests, and we can definitely figure out what's causing someone's low back pain, especially if it's in the first 2 categories. But a lot of times it comes from various other physiologic factors that really can't be nailed down specifically, so we end up with just non-specific low back pain in people that have it and live with it, and it can become chronic. So how do we associate low back pain with time? If you're talking to someone who's had low back pain for less than 6 weeks, we can consider that acute. If it's over 6 weeks, 6 to 12 weeks, subacute. Chronic is 12 weeks or more. So if you've been dealing with low back pain for over 3 months and you haven't necessarily gotten it figured out, or it hasn't decreased in intensity, we would consider you someone with chronic back pain, lower back pain. So approximately 90% of acute low back episodes resolve within 6 weeks. Within that acute, or maybe a little bit into that subacute period of time, if just think about it, if you had low back pain, you would want to get it figured out pretty quickly. And to reduce the probability that low back pain could become chronic and lead to disability, folks with low back pain should stay active, which is usually the opposite of what people think they should do. A lot of folks tend to think that when something is hurting, especially their lower back, that sitting for long periods of time or taking time off is really the best thing. And honestly, that's if we look at the literature, if we look at the research, and obviously we read what you guys are reading in this chapter, that can be one of the worst things you can do, right? And a lot of the reason that people tend to do that is they end up with some fear, anxiety, or misinformation regarding low back pain, and that can tend to those things that they do, where they sit long periods of time, they become sedentary, can exacerbate their pain. It can make it worse. So some things that folks can do to start taking care of their low back pain right away: therapeutic and aerobic exercise, pain education. Those types of things can improve outcomes, perceptions, and pain thresholds. So if you know somebody with low back pain that tends to take it easy a lot of the time, that might actually be the opposite of what they need to be doing. We know that exercise is a form of medicine and can really help people with low back pain become less chronic move them into a state of possibly healing. So just coming back to those psychological or psychosocial factors for long-term disability and work loss associated with low back pain. Low back pain isn't something to kind of shrug off. It can be really, really disabling mentally and physically, obviously. One of the things that kind of start to pop up are a negative attitude that back pain is harmful or potentially severely disabling. Fear avoidance behavior and reduced activity level. I'm in pain. I need to stop to feel better. And you may feel better initially sitting down, but over long periods of time, sedentary behavior can actually impact you the opposite way. An expectation that passive rather than active treatment will be beneficial. If I sit on the couch for a long period of time, then my pain will go away. Having chronic low back pain that reduces your activity levels can end up someone falling into depression, having low morale, and possibly social withdrawal, not doing things that they enjoy because they're in pain, which can lead to loss of work, which can also lead to increased social problems and maybe even financial issues. So when we look at some of the research, some of the most current research doesn't support a definitive cause for why people get low back pain right away. But because there's so many factors that go into low back pain. I mean, as far as everything that connects to your spine, it's a central location in your body. There's so many different factors, including the nervous system, that can lead to low back pain. But low back pain, previously having low back pain, is one of the strongest predictors for reoccurring episodes of low back pain. And the current guidelines place a heavy emphasis on preventative measures and early interventions to minimize the risk of an acute low back pain episode from becoming chronic, or a reoccurring low back pain episode after you're out of pain for a period of time. And the best evidence we have right now for treating low back pain is to indicate physical activity as a key component for managing that pain. When low back pain is a symptom of another serious pathology, so if we're talking about someone who has spinal stenosis or maybe a cancerous tumor in and around the spine, then exercise testing and exercise prescriptions should be guided by the considerations that we have to take into account from the primary condition, not necessarily the low back pain. Because in that instance, the low back pain is a symptom of something else that's causing it. So we have to assume that if that primary condition weren't there, neither would the low back pain as well. For all other causes associated with low back pain or less intense causes, in the absence of a comorbid condition. A comorbid condition would be, I have low back pain and I also have cardiovascular disease. So in that instance, recommendations for exercise testing and exercise prescriptions would have to be modified to consider low back pain and cardiovascular disease. If we don't have to worry about that, if we just have someone with low back pain and not a comorbid condition, then exercise prescriptions and testing are similar to healthy individuals with some modifications required. We will talk about that now. So as far as exercise testing goes, when we have someone with low back pain and we want to test their cardiorespiratory fitness, very few studies out there have actually taken people with low back pain and subjected them to an exhaustive exercise test, mainly because that would be contraindicated for someone with low back pain. As someone who's in pain, you don't want to take them to an exhaustive, vigorous state for an exercise test. whereas submaximal exercise tests are considered reliable and valid for individuals with low back pain. So your YMCA cycle ergometer test, your A-strand rhyming test, possibly a step test, or a submaximal exercise test on the treadmill. Now, the pain associated with low back issues could obviously limit submaximal testing, just like it would maximal testing. So therefore, the choice of maximal versus submaximal in individuals with low back pain would be guided by the exact same considerations we use for the general population. So what about muscular strength and endurance testing with people with low back pain? Individuals with low back pain typically have deficits, not surprisingly, in trunk muscle strength and endurance and neuromuscular balance. It's unclear if that deficit in strength and endurance and neuromuscular imbalance plays a role in the development and progression of low back pain. It might just be that decreases in muscular strength and endurance might be independent of the period and intensity of low back pain. So we don't have anything that necessarily has a concrete connection to muscular strength and endurance and neuromuscular imbalance are poor. That's the reason for your low back pain. We can't really say that right now. But we do know that people who have low back pain commonly do have deficits in these areas. But we can't say that those deficits are what causes the low back pain. So as far as exercise prescription is concerned, clinical practice guidelines for managing low back pain consistently recommend stay active, exercise, and avoid bed rest, avoid long periods of sedentary activity. People with subacute and chronic, so subacute would be 6 weeks and over, chronic would be that 12-week and beyond period. Folks who have low back pain, subacute and chronic low back pain, as well as recurrent cases of low back pain, are encouraged to be physically active. When you start getting into bed rest, sitting and being inactive for long periods of time, there has been evidence that shows that that could exacerbate your low back pain and make it worse, not better. When we provide recommendations for exercise prescription, they should follow closely the recommendations for general population as far as resistance, aerobic, and flexibility exercise go. Very closely aligned with general population recommendations. And when you're working with someone that has low back pain, especially chronic low back pain, it's really important that, because we don't know, in a lot of cases, remember 85% of cases, we don't know what's causing the low back pain. We just don't know. So the point that this slide is making here is that for really favorable outcomes with exercise prescriptions with people with low back pain, you have to individualize the experience, which we know that already. We know from the basic training principle that we learned in EXE 244 that not everyone is going to work out the same way. So you want to use an individualized approach that addresses psychological distress, fear, avoidance beliefs, and putting them in a position where they'll be successful and becoming more physically active, which we know is one of the primary recommendations for people with low back pain. So being more active rather than not, and tailoring their program to be specific for their needs. So when we look at special considerations for exercise programming for people with low back pain, trunk coordination, strengthening, and endurance exercises can be used to reduce low back pain and disability in individuals with that subacute to chronic low back pain. But there hasn't been any overriding evidence to date that shows that one specific type of therapy or strength exercise really works specifically to cure all low back pain, right? That's not something that we can necessarily say. We can't definitively say that someone has low back pain and they need to do more ab exercises and it will go away. That's not necessarily the case. That goes back to the individuality factor. There could be a combination of many factors that cause low back pain. Using one specific technique, it may or may not work. So when we're assessing someone's coordination, their trunk strength, their core endurance, right? Those haven't necessarily, there hasn't been one that's been proving ultra valid to let us know, okay, this person has poor trunk coordination in the overhead squat or in the hurdle step or whatever assessment you're using. That's why they have low back pain. So using one specific exercise to try and cure someone's low back pain isn't necessarily the approach. We know that global application of different types of exercises, trunk coordination, strengthening, and endurance exercises, could potentially reduce low back pain and should be something to focus on while you're individualizing parts of that program for that particular person. As far as abdominal work is concerned, abdominal bracing is something you definitely should not incorporate or use with extreme caution. Abdominal bracing is something where we have someone, and so if you have someone in a position and they holding my breath, really bracing my abs, that causes a compression on the spine, especially if you have somebody holding something, and that's not necessarily something we would want to see with someone with low back pain, is compressing that spine. Certain exercises or positions may aggravate symptoms, especially something like walking downhill. Walking downhill is a heavy eccentric exercise for the hips, the ankles, the knees. It requires a lot of force absorption in the lower body. If you remember that our body kind of acts like spring-loaded mechanisms, so walking downhill can be really, really jarring on the body. So that may exacerbate low back pain. You also want to limit any type of exercise. If you're doing an exercise with someone and they say, wow, my low back pain feels a little bit worse, and also the pain is starting to spread to my butt or my legs. You don't want peripheralization of symptoms. You don't want the pain to start spreading to other limbs. So a lot of it has to do with kind of picking and choosing exercise and seeing what works, especially if you have one of these subacute or chronic cases that have no particular underlying cause of the low back pain. Some more special considerations with people with low back pain. Repeated movements and exercises like prone push-ups that promote centralization or reducing pain in the lower limbs from distal to proximal are encouraged to reduce symptoms with patients with low back pain. So if you have someone that has low back pain and they're having trouble in their sciatic area, like in their glutes, it may be helpful to have them do more upper body exercises to help centralize the muscular focus a little bit more, and not necessarily focus heavily on lower body movements because that's where their pain is. Flexibility exercises are generally encouraged. Generally, we use that word strongly as a part of an overall exercise program. Hip and lower limb flexibility is always something that we can focus on, and we can assess. So many different assessments out there for hip and lower limb flexibility. Goniometry is one of them. One thing that's really highlighted heavily here, no stretching intervention studies have shown efficacy in treating or preventing low back pain. So we immediately saying to someone, you have low back pain, you should stretch more. that's not necessarily the best thing to say. It could actually make it a lot worse. We can't necessarily say that stretching interventions are automatically going to cure someone's low back pain. Could make them worse. So something also to keep in mind when you're individualizing exercise programs for someone with low back pain. And another consideration with someone with low back pain, progressive low intensity aerobic exercise for people with chronic low back pain. With generalized pain, a generalized pain is in more than one body area, or maybe their low back pain extends down to their glutes or up to their low back sometimes. So progressive low intensity aerobic exercise and maybe moderate or even high intensity aerobic exercise could be something that could help. A lot of times aerobic exercise is really great at promoting blood flow, which can be something that just makes your back feel better if you have low back pain, and helps the muscles become a little bit more plastic, so less stiff. Things to think about there, another consideration for exercise programs, people with low back pain. Okay, so now we are going to move into a section that deals with exercise considerations for older adults, and this is really pertinent for the part of our class that deals with exercise programs for older adults in the Franklin Fit program. As far as someone who is an older adult, who is that? Individuals 65 years old, at least 65 years old, and individuals between 50 and 64 with significant clinical conditions or physical limitations that affect movement, physical fitness, or physical activity. You could be 50 years old and move better than a 20-year-old. Or you could have a clinical condition that really affects your movement capabilities. So as far as older adults we consider that a pretty broad, diverse spectrum of ages. That's, obviously we wouldn't necessarily call a 20-year-old an older adult. So it really starts at about that 50-year-old range, depending on how well they move and how well they physically function. Health and functional status are often better indicators of ability to engage in PA than chronological age. I just mentioned that. You could have somebody that's 60 that's in relatively better shape than someone who's 20. I mean, a 20-year-old who just sits on the couch, plays video games, watches Netflix, doesn't really work out, doesn't get any physical activity, versus a 60-year-old that's super active every single day, lifts weights, goes for runs. So chronological age, how old you are, isn't necessarily a predictor of how well you function health-wise and fitness-wise. But as far as the category is concerned, older adults we can categorize them between 50 and 64, but definitely at 65 years or older. Evidence exists that supports the benefits of physical activity in older adults. A lot of different factors that increasing physical activity can have an effect on, can slow physiologic changes of aging that impair exercise capacity. It can optimize age-related changes in body composition, promote physiologic and cognitive well-being, manage chronic diseases, reducing the risk of physical disability, and increasing longevity. Why would you not have someone do more physical activity as they get older? Even more so than they did when they were younger. These are all the reasons why you should. They are the least physically active of all age groups. Only about 11% of individuals at least 65 years old engage in regular aerobic and muscular strength training activities. Less than 5% of individuals older than 85 engage in regular aerobic and muscle strengthening activities. That's not great. If we look at the effects of aging on physiologic and health-related variables, a lot of things that won't surprise you here, but it's really good to review this stuff so that we can understand when we start talking about exercise testing and exercise prescriptions, why it's important to make special considerations for older adults. So if we just go down the line there, resting heart rate actually remains unchanged. That is typically a factor that is a result of overall fitness. You could have somebody that's older that has a very low resting heart rate. So resting heart rate is generally a factor that's really impacted by overall fitness. Now, maximum heart rate is going to go down. That's really affected by age. So the older you get, the maximum heart rate that you can achieve will be lower, as is your cardiac output, heart rate times stroke volume, cardiac output, if you remember that from exercise physiology. Resting and exercise blood pressure is typically going to be higher. And again, these tables are based off of studies that have been done with lots and lots of different people. So it doesn't always mean that your resting and exercise blood pressure is going to be higher if you're an older adult, just on average. Absolute and relative maximum oxygen uptake reserve. So we've talked about heart rate reserve and VO2 reserve. Remember, reserve is a word that really means that window of opportunity that you have for exercise capacity. So if your heart rate reserve, for instance, if your heart rate rest is really high when you wake up in the morning, your heart rate reserve is a much lower number. Same thing with VO2 reserve. So we have a lower open window or capacity to use oxygen to make aerobic ATP as the older that we get. Residual volume is the amount of air that's left in your lungs as you breathe out. So if we're not able to get as much air in and out of our lungs, you can see vital capacity is also lower. Then obviously oxygen transport in the lungs and then to the cardiovascular system is going to be diminished as well. Then you can see all the other areas that actually, go down. Reaction time is slower. That has to do with loss of activation of type 2 motor units, muscular strength, flexibility, bone mass. So things definitely start to decrease as you get older. Fat-free body mass, so muscle tissue in general. There's some atrophy as people get older, especially if they're sedentary and not working out. And then body fat percentage on average tends to be higher. Glucose tolerance, so your ability to use your metabolism's reaction to glucose with insulin response is lower. And then that, all of that decreases your recovery time too after exercise. When we're looking at testing older adults, exercise testing, especially when we're using a treadmill, a lot of times a handrail support will definitely increase comfort on a treadmill. As adults get older, the potential for falling will increase. So obviously a treadmill might be something that could induce some anxiety and fear. Well, one thing to take into consideration is the reason we use a treadmill is because it mimics overground walking, right? And typically when we walk, that doesn't necessarily include holding on to something. And that can affect the accuracy or the estimating peak VO2 or peak MET capacity during the test. So when we do an exercise test, it's generally to get an idea of how much someone can do. And if you're holding onto a treadmill railing, that will could definitely decrease or diminish the accuracy of the test. Treadmill workload may need to be adapted according to the walking ability. And one of the ways you can adapt a treadmill is to increase the grade instead of the speed, right? And there are a lot of treadmill protocols and tests that we can use that would do that rather than increasing speed. So what type of exercise tests would we use on an older adult? We obviously have a lot of tests available to us that we can use, standardized tests, submaximal tests that we've done on the cycle ergometer and on the treadmill. A better estimation of someone's ability to carry out daily tasks would be some of these commonly used physical performance tests that you see in Chapter 7, like the senior fitness test, short physical performance battery, gait speed testing. So we test exactly how fast someone is able to walk, which is a pretty good indicator of just general performance. The 6-minute walk test is always a great one. And then continuous scale physical performance test. That's a pretty big test, lasts for a long period of time. It's a great test if you have the time for it, but some of these other ones that are noted here are really, really great tests, and they can give you an estimation of someone's ability to perform just standard daily tasks, or ADLs, activities of daily living. So these are some great tests that you could use for your client at Franklin Fit. As far as exercise prescription goes with older adults, the fit recommendations for older adults aren't that much different than regular, I should say regular, or just general population, non-older adult populations. Not that much different. And you can review the fit recommendations here. When we start making your exercise prescriptions for your Franklin Fit clients, this would be a really good go-to resource. So when we talk about neuromotor exercises for older adults, when we say neuromotor exercise, it's just a category of what you're trying to work on. It doesn't necessarily mean one specific or specific exercises. It's really how you set up the exercise. And neuromotor exercises, or the way you're using these types of exercises in your program, are set up to work on proprioception, agility, and balance. And we've talked about proprioception in a lot of our classes. In exercise physiology, we talk about it as well. It has to do with those Golgi tendon organs, muscle spindles, and mechanoreceptors that are inside your muscles. So if I close my eyes and I hold my arm and my elbow at 90 degrees, I can't see it, but I know it's somewhere around 90 degrees. If I open my eyes, yeah, it's pretty close. That's proprioception, right? My nervous system can actually tell that my elbow is close to 90 degrees without even looking at it. Older adults might lose the ability to use proprioceptive abilities well. That's because neuromotor function, or the function of the motor units, kind of diminishes over time, especially the type 2 motor units. So if you think about the nervous system having to coordinate movements, right? Muscles have to fire at exact times in exact sequences in order for things to happen, especially like walking. And if that starts to go down, then we start to have trouble with things like walking in a straight line, navigating steps, and the possibility of falling increases. So we want to set people up to work on this area of improvement, so the fear of falling goes down. And what that looks like could be a number of things. You can use that 6-step progression that we talked about to progressively increase the difficulty of postures. And one way to do that is base of support. If you remember back to EXE 244, your base of support, if these are my feet, right? My base of support is really wide, and I'm set up like right now. Let's see, let's back this up a little bit. If my feet are really wide, right? My feet are really wide, I have a really good base of support, right? So then we can do a 2-legged stand, right? And I can split my stance. and I can reduce my base of support or where my feet are. So if I go to a split stance, or I have my feet directly behind one another and then up to one-legged, I continuously reduce the base of support, and that is a way to increase the difficulty when we talk about neuromotor exercises. As far as perturbing the center of gravity, perturb means to disrupt, right? So then when we start to get people more comfortable in these positions where their base of support might be a little more challenging, then we can start to add some movement to it that's going to challenge the center of gravity, right? And a way to think about this also is that center of gravity is when you want to be the most stable, you lay yourself on the ground. You're super stable. Your center of gravity is on the earth, literally. And then the higher up off the ground we get, the more we challenge that stability. So the higher your center of gravity is. So if we're in a tandem walk, that means one foot directly behind the other and turning in a circle or twisting in a circle. That's really going to challenge not only our base of support, but now our position with our center of gravity. So those are just some easy ways to work on neuromotor function with older adults. So to continue with neuromotor exercises, some general recommendations: stretching. There you go. That's stressing postural muscle groups, like let's say heel to toe stands. Postural muscle groups would be muscle groups that help us stand, right, or sit upright. So using eyes closed exercises, things like Tai Chi that involve or demand really smooth movements while you're moving in different planes of motion. And obviously, if you're challenging someone with these types of exercises, you want to monitor their progression. You want to supervise them, especially if you're going to have somebody close their eyes. Muscular strength decreases rapidly with age. That again goes back to some loss of just muscle tissue, atrophy, especially if someone is really, really sedentary over a long period of time. So your body is really good at using what it needs, developing adaptations for what it needs, and that can go forwards or backwards. We can increase muscle mass by lifting more weight over time, hypertrophy, or if we're not applying forces or requiring motor unit activation in really sequential patterns, then we don't need that muscle tissue, right? Atrophy starts to happen. It's the opposite of hypertrophy. So muscular strength, which involves the amount of cross bridges that we can make and the amount of force we can apply, will diminish. If we're not using those motor units, the tissue will start to atrophy and we won't have as much strength. And so this is something you could possibly expect in an older adult population. So what does this mean as far as what should we do to help decrease this diminishment of motor unit activity, especially type 2 motor unit and type 2 muscle tissue? Power exercises. So remember, muscular power is the length of the tissue is set, right? So my bicep, right, has a set length. How quickly can I contract that tissue? So if my bicep is this long, how fast can I get it from here to here? That's power, right? The amount of work done over time, force times distance over time, is power, right? So muscular power is the ability not only to contract those tissues really fast, but turn on those type 2 motor units. And if we're getting older and we're getting some muscle atrophy and we're not able to turn on those motor units as well, using muscular power exercises can really help us sustain that ability. So we should include power exercises with older adults. They can benefit from power training, and we should use it in our exercise programs. So what would that look like? You could do single or multi-joint exercises. I prefer multi-joint exercises, especially for power training, 1 to 3 sets using a light to moderate load. See, that says 30 to 60% of 1 RM, but we're not necessarily going to do 1 rep max for someone. So it should just be something that you require them to do rapidly or with a little bit heavier load than usual. And that, for some people, might be body weight even. I like the 6 to 10 repetitions with high velocity. So using a lighter weight where we have to go a little bit faster, and that's power training, right? Now, as far as using power training, you would want to focus on strength first, just the ability to move weight, and that could look different for people of different ability levels and different ages. So as far as someone with sarcopenia, sarcopenia is just lack of muscle tissue, having less muscle tissue than what is needed for daily demands or doing exercises in the gym. So we would need to build up that muscle tissue first by doing just general strength training with the older adults, and then move into power training after that. If someone has an ability level where they're already comfortable doing some weight training, and they have an okay muscle tone, okay ability, you can move into power training right away. So now we're going to move into exercise testing, exercise prescription for people who are pregnant. Healthy pregnant women without exercise contraindications are encouraged to exercise throughout pregnancy. That's something that's typically been a misnomer in the past. When someone's pregnant, we should stop moving, we should rest. Then even a long time ago, it used to be that pregnant women would go on strict bed rest. We know that's not the case now, so there's a lot of misinformation out there about do I exercise when I'm pregnant or not? And the answer is yes, you should, definitely. What are the benefits of exercise during pregnancy? Prevention of excess gestational weight gain, gestational diabetes, decrease of preeclampsia, decrease of incidence and symptoms of low back pain. You have to remember that when someone is pregnant, their center of gravity shifts quite a bit, and it's going to shift frontwards because the stomach area obviously grows, and that's going to shift the center of gravity, which means if something is if there's a big load out in front of me, what am I going to have to do? I'm going to have to bend backwards to make sure that I don't, fall over. And that can put a lot of stress on the low back. So there are exercises that we can do to help strengthen the core musculature and decrease the possibility of low back pain. Decrease risk of urinary incontinence. The pelvic floor musculature, so the musculature that surrounds the lower half of your pelvis is put under quite a bit of stress, eccentric stress, when a woman is pregnant, because it stretches out quite a bit. So during exercise and during just daily activity, there is the possibility of just leakage and urination, involuntary urination, because those muscles become so stressed. So there's lots of exercises we can do to improve the strength of that musculature and decrease the risk of urinary incontinence. Prevention and improvement of depressive symptoms. We know that exercise has a lot of great psychological benefits, especially for anybody, but even pregnant women can benefit as well. Maintenance of fitness. You don't want, if you have a pregnant woman who's active quite a bit, you don't want to lose all that, and you can maintain your level of fitness all through pregnancy. And prevention of postpartum weight retention, that's a big one. A lot of times, or sometimes with women who get pregnant, their weight increases quite a bit, and they keep the weight after the pregnancy, so it's really hard to get that back down, get their BMI back down within levels that are acceptable for their age, their gender, so exercising during exercise can help that. As far as exercise testing goes, maximal exercise testing shouldn't be performed on women who are pregnant unless medically necessary. If a maximal exercise test is warranted, the test should be performed with physician supervision. Typically not going to see a need to do maximal stress testing on a pregnant woman. What would be the contraindications for exercising during pregnancy? So what are the things that tell us that we should or we shouldn't exercise during pregnancy? So a relative contraindication, remember, is something that when we say it's relative, that means that we are deciding that the risk, this is the risk, is the risk higher than the benefit? Or is the benefit higher than the risk, and then we continue doing it? That would be a relative contraindication. Absolute contraindications for exercise during pregnancy would mean no exercise whatsoever if we have any of these contraindications, any of these existing contraindications. This would be a good slide to review. Could be some good test questions in here. Now, more on exercise testing with pregnant women. You have to remember that we have with someone who's pregnant, you have a fetus growing inside, so that essentially requires an excess amount of energy to provide metabolism and growth for the fetus. So that is an excess amount of energy going from the mother that's well beyond what it would be if she wasn't pregnant. So because of that, using submaximal testing protocols to predict your VO2 max, like a YMCA cycle test or an A-strand rhyming cycle test, you can assume that those predictions are going to be accurate because the energy output at rest is higher even, right? But what they can do, what those tests can be useful for, is to predict the effectiveness of training. So I can do a submaximal exercise test, at the beginning of my training to see where someone is at, where a pregnant woman is at, and then I can use it again to track their fitness levels. So they necessarily become progress markers, not necessarily to predict VO2 max, but to see where someone is at and how well your training program is working. What would the physiologic responses to acute exercise during pregnancy be compared to a non-pregnant person? An acute exercise, to remind ourselves, is when we begin exercising, like right now. If I start exercising right now, what would the acute physiologic effects be? What would happen in my body right now? So if we take a look, almost everything increases. VO2, oxygen uptake during weight-dependent exercises, right, would increase. So anytime we're using something where we're moving our body weight, our VO2 is going to be higher. VO2 is going to be higher in a pregnant person than the non-pregnant person. Heart rate increases, stroke volume, cardiac output, tidal volume, minute ventilation. Ventilatory equivalent, so how much oxygen am I using compared to how much I'm breathing, right? Ventilatory equivalent for CO2. How much CO2 am I putting out compared to how much I'm breathing? Remember, ventilation is just air in, air out, and that's VE, right? Systolic and diastolic blood pressure, no change, or it could go down. Why is that? Everything else is going up, right? Except for blood pressure. In a healthy pregnant woman, the cardiovascular system, it's actually pretty cool. It adapts very, very quickly, right? And so the cardiovascular system, the pipes, the dilation of our veins and arteries and arterioles actually increases, and the response to that goes up. So, well, then why doesn't cardiac output go up? Well, cardiac output and stroke volume have to do with your heart's ability to pump. So we're comparing now pregnant to not pregnant. So those adaptations come over a period of time. But systolic and diastolic blood pressure can actually change very, very quickly. And so we could see not much change or a decrease in that diastolic blood pressure and systolic blood pressure during exercise. And we should see diastolic go down anyway. That's normal. What about exercise prescription for women who are pregnant? Research on the effects of resistance exercise during pregnancy is limited. We don't have a ton of research on that. But compared to sedentary people, resistance training can have no effect or produce better outcomes, lower incidence of low back pain, shorter labor duration, shorter recovery time, and faster return to activity. I personally have worked with people who have been pregnant and exercised during pregnancy. They'd exercised before, they exercised during pregnancy, and their return to normal activity and to normal weight was much, much, much quicker. Right? So, and the ability to be in labor less and have a shorter labor, labor or having a child involves a lot of muscle activity, right? So utilizing that muscle tissue during labor can be a lot easier if the muscle tissue is stronger, right? So exercise during pregnancy is that much more important, and there could be some definite benefits to resistance training particularly. What would be the fit recommendations for women who are pregnant? All right, some things to pay attention to on here would be frequency, intensity, time, type. Not super different than people who are not pregnant, with just some minor differences. So please review the fit recommendations for women who are pregnant and have a really good idea of this. Could be some good questions for a quiz or a test. What about exercise training considerations when pregnant? So particular things that we have to take into consideration while we're training someone. There's not necessarily an ideal number of days. Frequency during pregnancy should be regular, right? Occurring throughout the week and adjusted based on total exercise. So there's not necessarily, follow the fit recommendations, but this is an individual thing, right? Heart rate ranges corresponding to moderate intensity exercise have been developed, but because they change when someone is pregnant, it's a little bit tougher to use heart rate. It becomes much more variable when someone's pregnant, especially since the fetus continues to grow. So as the fetus gets larger and larger and larger, the heart rate continues to change throughout pregnancy. So RPE could be a better indicator to monitor intensity versus heart rate. And also keep in mind with pregnant women, just as with normal populations, accumulating shorter bouts of exercise, 10 to 15 minutes, is fine. Right? So we can accumulate our physical activity and our exercise throughout the day if longer bouts are a little bit harder to do. So going back to the heart rate, the heart rate that we talked about and how heart rate, remember moderate intensity is our target, right? So this chart is actually really interesting. It's based on a couple studies that have been done with pregnant women and exercise. And the first thing that you want to do is take a look. I'm going to take myself off the screen. Take a look down here to your index, right? That's something you want to pay attention to when you look at this. This could be, again, a really good resource for some test questions. If we're looking at pregnancy, and one of the first things we start to look at when we interpret this table, right, is what are we talking about as far as weight? Some pregnant women maintain their weight fairly well, except for the additional weight of the fetus. And some women gain more weight. That's an individual thing. It's not necessarily have anything to do with how much they eat. Just some women tend to gain more weight than others, if we're assuming that all of these women are physically active, right? So if we're looking at, there's two different categories here, pregnancy with people with a BMI of 25 or under, and then at 25 or over. And keep in mind that as pregnancy progresses, you could move into the higher category just because the fetus is getting larger, right? So we have, then our next category would be fitness level, age, fitness level, and heart rate ranges. So our fitness levels are unfit, active, and fit. And if you look down at the legend at the very bottom, that is defined as a percentage or a percentile of VO2 peak. So if you look down at the legend at the bottom, right here, right? Oops, sorry about that, but you get where that's at. If you look back at your VO2 charts in our previous chapter, that's where we're getting these fitness levels from, right? So someone can be pregnant and we can still measure their VO2 peak. Remember, VO2 peak is a little different than VO2 max, right? VO2 max would mean that we level off our VO2 when the intensity is being increased. You can review your notes on that. But a very fit person is in the top 25th percentile of VO2 peak for pregnant women at that same level. And then target heart rate ranges, if we look down at the very, very bottom, if you're looking again in the legend right here, what does that mean? Target heart rate ranges, where did they get that? They actually did peak exercise tests in these studies on healthy, low-risk women. So that's where they gained the information on these target heart rates. So this is good information to have. It's great to use heart rate. It's a little bit tougher when someone's pregnant, but at least we can have a range to look at with this table here. When some more considerations when we're training pregnant women. One of the biggest things that we have to think about here is what has someone been doing before they were pregnant? What is their fitness level before they were pregnant? So previously inactive women, they can begin exercising when they're pregnant. Now, this used to be a thing like, hey, look, don't start exercising if you haven't been exercising. But it's okay to begin exercising when you become pregnant, even if you're not super fit to begin with. Start with 15 minutes a day, 3 days a week at the appropriate RPE or target heart rate to approximately 30 minutes a day for most weeks. So if you become pregnant, start exercising. We know there's benefits to it that we discussed previously in this lecture. What about women who habitually participate in resistance training, right? So weightlifting. And I've worked with people who have done this, and I've had clients who have been into heavy weightlifting, and then they become pregnant. Should they continue to resistance train? They can still do resistance training. Absolutely. You just might have to modify the intensity a little bit, decreasing the weight and doing more reps. Same thing we would do with the aerobic training. If you're used to running at a 10-minute per mile pace on the treadmill for your 30-minute run every day, you might not be able to run that fast when you're pregnant, but you can still do aerobic training. Same thing with resistance training. If you're used to deadlifting 135 pounds off the floor with a bar, as an example, I used to work with a couple women that were very, very fit. And I mean, they'd be lifting 200 pounds, 1.5 to 2 times their body weight in their normal workouts. Now, when they were getting into their first trimester, they could still do that, no problem, right? Second trimester, we had to start to modify a little bit, decrease the weight, do a few more reps than we normally would, and go from there. So resistance training can definitely still happen during pregnancy. There's lots of benefits to it that we even discussed earlier in the lecture. And then as far as the pelvic floor, which is an extremely important part of pregnancy, exercise training during pregnancy. Kegel exercises that strengthen the pelvic floor can reduce the risk of incontinence during and after pregnancy, and especially during exercise. Having control of that musculature can really help. Even non-pregnant people, when someone's exercising at extreme levels, incontinence can occur. I mean, you can pee yourself. You just can. So when you don't have control of that pelvic floor musculature as well as you normally do, when you have an enlarged uterus and fetus sitting on top of your pelvic floor, the musculature starts to become stretched in an eccentric position. So it's a lot harder to control that musculature. Those are really, really important exercises to include with someone who's pregnant. Other special considerations. Physical activity in the supine position should be avoided or modified after 16 weeks of pregnancy, right? So supine position, laying on your back, right? That would be the second trimester. So once we move into that period of time, no more laying on the back exercises, right? Women who are pregnant should avoid exercising in hot and humid environments. So just like every other physiologic factor that we looked at a few slides ago, the ability to cool yourself when you're pregnant diminishes because a lot of your metabolic resources are going towards providing sustenance for the growing fetus, right? So we can see in the next point, metabolic demand increases by at the very least 300 kcals per day. So at rest, let's say at rest, if you have a woman that burns 2,100 calories, 2,100 calories just at rest during the day, on a rest day, no physical activity, that being pregnant is going to shoot up to, at the very least, 2,200, 2,300, 2,400 kilocalories a day. Your metabolism is going to go up that much, right? Nutritionally, you may learn about this in nutrition, you're going to have to increase your caloric intake anyway, right, to support the fetus. Now, if we're adding exercise on top of that, you're also going to have to increase your caloric intake to make sure you stay balanced. And the last point there is, I'll move myself out of the way, physical activity may help regulate weight gain during pregnancy, which is a big factor. There are definite issues that can come into play if you gain too much weight during pregnancy. Gestational diabetes could be one of them. So we know that exercise helps regulate insulin response, and that will continue to be the case during pregnancy, which can also help regulate weight gain during pregnancy. A few more special considerations for exercise training with people who are pregnant. In the case that we have someone who is already severely obese, has a very large BMI, and has become pregnant, or has developed gestational diabetes developed during pregnancy, or has high blood pressure, hypertension, those folks should definitely consult their physician before they begin an exercise program. Right? And then your exercise program, just like anything else, just like with any other population with special considerations, your exercise prescriptions will be individualized and modified to meet those specific needs. So someone who's a little bit higher risk for contraindications to exercise, someone who's more obese or has special considerations should definitely meet with their physician before beginning an exercise program. Next one's super obvious. Avoid contact sports with women who are pregnant. Avoid doing super high contact or heavy exercises, right? Olympic lifts are probably not the best exercise to do when you're exercise. Not probably, they're not. They're terrible exercises to do. Gymnastics types movements and things like that aren't the greatest choice of exercises when someone's pregnant. And one thing that might not necessarily be assumed when you're training someone is that a lot of people hold their breath when they exercise. That's called the Valsalva maneuver. So the Valsalva maneuver, looks like when we get when we're doing some heavy weightlifting, and you bear down, and you create a lot of pressure inside your body, which is great to help you lift heavy objects, barbells, things like that when you're exercising. Not great when you're pregnant. It severely increases your blood pressure right away, right? And so does isometric contraction. So avoiding the Valsalva maneuver and avoiding prolonged isometric contraction, motionless standing. The name of the game is movement, and dynamic movement, continuous movement would be a lot better than doing prolonged isometric contractions, and definitely not the Valsalva maneuver. So our final consideration when we're talking about exercise training with someone who is pregnant: when can I go back to my regular exercise training after delivery? So delivery of a baby itself is a huge, intense undertaking, not something that someone like myself, like a male, could ever understand. But it is a super intense undertaking. It's very, very tough on the musculature involved, especially if we're talking about a cesarean procedure where you actually have to cut into the abdominal tissue. So physical activity and exercise can be resumed after pregnancy. A lot of that, the when, is usually determined on the fitness level or the cardiorespiratory fitness level of the individual after or during pregnancy and before they were pregnant. So generally speaking, 4 to 6 weeks for a regular vaginal delivery, and then 8 to 10 weeks if you had a cesarean delivery. And those are estimations. If you have someone who has high cardiorespiratory fitness and was exercising more rigorously even during pregnancy, they may be able to return even quicker. And I've worked with clients that's actually been true. Worked with someone who was doing lots of vigorous training during pregnancy, had a great pregnancy, super fast labor, and was back inside of 2 weeks just doing normal physical activity. Not everyone is going to have that ability, but the level of fitness before pregnancy, during pregnancy, will dictate how quickly they can return. And returning to exercise is important. Light to moderate intensity exercise, returning to that is important because it can help start to get someone back to their pre-pregnancy weight and BMI, which is really important. And it doesn't interfere with breastfeeding either. A lot of questions would come into, well, if I'm exercising after I've had a baby and I am breastfeeding, does that extra caloric output with my exercise interfere with my breastfeeding? And it doesn't. It actually doesn't. So some considerations to take when someone is returning to exercise after pregnancy.